Thanks, Ash. Thanks, sponsors. Thanks, speakers. Thanks, everybody. Phil, I would shout out to my students, but they're not going to be on. This is the last week of the semester. The third year students, I just gave their final. They're probably doing what you're doing right now, um, which was drinking. And then the others are studying for finals, so there's no need to shout out to them. I'm going to shout out though to the general because I'm almost positive
The general,
general's
I
always
saw him.
on.
He's on.
Is he on? The general.
Yet.
Shout out to the general. Yep. All right.
Didn't look yet.
So anybody, this is Rob Manske, Wichita State University, Ascension Via Christi. Thanks for joining us tonight. We got a great two topics. These are one of these papers. We'll get to them in a minute. Is a little bit older, and then one's newer, but they're really good topics on both of them. So, Phil, do you want to introduce yourself quickly?
Sure. Phil Page, a professor at Franciscan University in Baton Rouge, Louisiana, in physical therapy. Thanks, Ashley, and to all of our sponsors, and of course our guests for being here. And Rob, thanks for making sure this all goes well with that beard.
Oh, Phil, before you go, you know what number this is tonight?
I'm going to say 49.
49. You got it. Bingo. 49. We got the big 50 next month. Can you believe that? Can you believe that, everybody?
Yeah.
Almost 50.
He's got it.
Phil's got it. All right, Barb.
I'm Barb Hoogenboom. I hail from Grand Rapids, Michigan, but I'm in our house in Colorado right now because I'm recently retired from Grand Valley State University. But I am the editor-in-chief of IJSPT and super glad to have our guests on tonight. And thanks to all our sponsors for all you do to make this journal club possible. So I hope we can have a fun and entertaining time tonight, which we will.
We should. All right. I'll introduce our first guest, and then our first guest is going to introduce himself and our second guest. But our first guest is a very longtime friend of all of ours, Terry Malone. Terry, I'm so glad you're on. Terry and I used to do some courses for Northeast Seminar. I don't know how many we did. We did it for like a year and a half, maybe 2 years, and so I traveled all over the U.S. with Terry, Bob Mangine, and Russ Payne. And so I've known Terry for a long time. Great guy. Terry's going to be great with us tonight. And so Terry, just tell everybody who you are, where you're from, why you're on, and then introduce Dr. Mair, if you don't mind.
I'm really glad that Grizzly Adams was able to join us tonight and share those thoughts. And I'm Terry Malone. I'm a professor of physical therapy here at the University of Kentucky. I'm actually semi-retired, but I'm still in an office because I am executive chair of the medical IRBs for the university. So I still get to teach and have fun, but I spend a lot of my time doing things that are less than enjoyable at times. But I've been very, very fortunate and very blessed to be a part of a lot of things related to the shoulder that we're going to be sharing tonight. I think as therapists, the number one thing that you need to remember, always observe. And that's a real skill that you develop over time, but it becomes second nature. And observation is a big part of what led us to where we are related to the shoulder and pitchers. And I'd just like to start with saying I was a pitcher and a third baseman, and I have this significant difference in right and left arms. And that was always a question, why? And that observation led to some of where we are today. So I'm very, very blessed to have been a part of a lot of that. Along the way, I was at Duke University and started the sports medicine physical therapy part of that, and had this resident by the name of Mair. And Dr. Mair was, for those of you who don't know, the Duke Orthopedic Residency Program at that time was one of the top 5 in the country. And so if you got to be selected to be a Duke orthopedic resident, you were pick of the litter. And then this pick of the litter, Dr. Mair then went on and did a fellowship with this gentleman by the name of Dr. Hawkins and Dr. Stedman. And I was very, very fortunate to be able to help recruit him to the University of Kentucky when he finished. And we've been together for over 30 years now, basically, here at the university. So we've been very, very blessed. And anything you want to add, Scott?
Well, thanks for helping me get a job. I appreciate it. And you may have been here for over 30 years, but I've been here 28 at University of Kentucky. So we both had more hair and different colored hair back then, but very blessed that I ended up here. I had never been to Kentucky before I interviewed here and didn't know a lot about it, but certainly found that Lexington's a good spot, and you were very instrumental in me interviewing here and getting started here, so I appreciate that.
And for those of you that haven't perused the literature on a regular basis and then gone to a lot of orthopedic meetings, Dr. Mair is a shoulder specialist. And of course, we've kidded him the last 2 years because we can't keep a point guard on the court, but that's another matter with shoulder problems. So, okay, true. Rob, it's up to you.
All right, you guys ready to start? Let's talk about our first paper here. The lead author on it is Dr. Mair. We also have Tim Uhl, which a bunch of us know on this paper. It was this was the one I was talking about that was published a little while ago, to 2004, in the journal Shoulder and Elbow Surgery, and the title is Physeal Changes and Range of Motion Differences in the Dominant Shoulder of Skeletally Immature Baseball Players. So the purpose of this study was to document radiographic findings and range of motion measurements in throwing shoulders of Little League baseball players with an open proximal humeral physis. And then a second goal was to compare the incidence of radiographic changes with non-dominant shoulder to the non-dominant shoulder and what degree the changes resulted in symptoms. One of the things I love about doing the journal club is that we can read these we get to read these articles, and some of these articles, like this article, I hadn't read before. So I was glad to be able to read it. And it talks about Dotter, Dotter, an author who described this phenomenon, the physeal changes, clear back in '53. And I was shocked. It was a lot longer ago than I thought that they would have been looking at that. And I assume diagnosing those problems were probably just done, I assume, Dr. Mair, and this was before you were practicing too, but I'm assuming it was just with radiographs and a good medical history, probably back when in '53.
Yeah, and I think, if I'm not mistaken, he termed the coin Little Leaguer shoulder, which goes back pretty far. And yeah, I wasn't around in '53. I think Terry was. But yeah, he was the one who noticed on X-rays that Little League pitchers with shoulder pain had X-ray changes and coined that term. And obviously, we've learned a few things since then, but got to give him credit for finding the changes at the growth plate that kind of led to a lot of the studies.
For sure. So can you tell us, just to kind of start us off here, what's a normal finding at the physis of the humerus in a skeletally immature baseball player, and what's abnormal, and what measurements do you take to determine that pathology, to determine whether it's pathology or just their normal growth? Yeah. What kind of things? Yeah.
Well, so that's part of the thing. Well, first of all, this study, when I got here, we had Tim Uhl, who's obviously fantastic with research, and we both had interests in baseball. And that was around the time where people had sort of finally started to talk about increased retroversion in the throwing shoulder and things. Up until around late '90s, probably, or mid '90s, people assumed that the reason throwers had increased extra rotation in their throwing arm was because they stretched out their soft tissues, which would make a lot of sense if you just wanted to come up with a reason for throwers having more extra rotation in the throwing arm. You'd assume it's from stretching those structures, but people had started to find that there were bony changes in throwers, and it's been documented zillions of times since then, but and now there are good studies with CT scans and things that show that a lot of throwers have 15, 20 degrees, even more retroversion of the throwing arm compared to the other arm. So one of the things we wanted to do in this study, there was a study that showed that you could do that with x-rays. And so we got these funky x-rays with Uhl designed this thing to put their arm in to get the x-ray just right, looking down the pike and look at their physes and compare the version. And it really didn't work at all for kids. So that was the driver of the study, was trying to look at retroversion, and we didn't get any good data on that. But he did get a lot of great data on range of motion, and kind of showed that the older the kid was and the more they threw, and that it was kind of a relatively straight path to more and more extra rotation as compared to the contralateral side. And the x-rays did show us some interesting findings as far as the growth plates and things, but the retroversion stuff didn't really pan out. So to answer your question, I think there were 79 kids in the study, and the radiologist so we had a blinded radiologist, not blind, but blinded to which was the throwing side. And we didn't tell her which was right, which was left. And we just Uhl had a system to kind of keep track of that. And she was able to figure out in 45 out of 79 which one was a throwing shoulder, just based on x-rays. And most of these kids were asymptomatic. Obviously, we just recruited 79 little leaguers from age 8 to 15. And she was only wrong once, and then there were 33 where she said there wasn't enough change to tell the difference. And a lot of the assumptions were that the more you threw, the more the changes you would find. But basically, you would see widening of the physis on the lateral part of the growth plate in the throwing arm. More than half the time she could see that, as compared to so we x-rayed both the throwing and the non-throwing shoulder and compared them. And more than half the time, probably close to two-thirds of the time, she could tell which was the throwing shoulder based on just an x-ray. And again, those didn't have symptoms. So when daughter said that little leaguer shoulder was changes on x-ray, one of the things we found was that it was kind of ubiquitous to throwers and didn't necessarily correlate with symptoms.
So, Doc, did she look at the actual, was the change just compared to the other side, or is there a certain threshold of widening typically that makes you think that maybe it's symptomatic? So
the best comparison in this study was to the contralateral opposite side, because the older they get, the more the growth plate may start to close, that kind of thing. And obviously the really young ones, the growth plate looks crazy. But so she was doing it all with comparison to the opposite side. And we had 79 kids, we didn't have thousands. So, you're trying to, we couldn't answer every question about symptoms and things. And there weren't that many that had symptoms. But one of the things we found is that when we asked the ones that had symptoms, that, I think it was in the past year or something, there really wasn't much correlation, at least in our group, our limited numbers, between the amount of widening they had at the physis and whether they had symptoms or not.
So the widening then doesn't correlate with, years of pitching, years of baseball participation, pitching volume, or position, or anything like that. There's no real correlation that you guys found.
Not within our limited numbers. I suspect if you had enough numbers, you would find that, the ones with more widening might have more symptoms. They might be the ones that pitch the most, all these things that you would assume.
Yeah. You think there's got to be a threshold, probably, right? I mean, there's got to be some threshold, because otherwise it wouldn't be wider on that side. But I guess that's the question. Where does that threshold, where do you draw the line?
Right. So the growth plate is what sees the stresses in a young kid. Obviously, as you get older, it's different things and different things we worry about. And we're going to talk about a lot of this, but again, to correlate it back to the thing that we couldn't measure, the increase in retroversion, the fact that the growth plate seeing changes I'm sure it has to do with the fact that as you're throwing and as you're growing and the growth plate seeing those stresses, it's gradually slowly over time, twisting basically.
Mm-hmm.
More extra rotation. And there are plenty of studies since ours that have shown that increase in extra rotation and increased retroversion of the throwing shoulder is a good thing. It's adaptive to throwing. It helps you throw probably harder, and it may protect against injury. So all these things in time are helpful. Obviously, as you mentioned, there's a threshold where if you throw too much and the growth plate twists too much or you get symptomatic, then you're into the little league or shoulder realm where now you have symptoms related to your growth plate. So
Yeah.
There's some adaptation and there's some risk for both pain, and I guess you don't see it very often. It's a lot. We're not talking much about elbows in this study, but elbows is kind of the same thing, but the elbow physis can actually pop off if you get enough forces to it, or if you throw through symptoms. Not very common in the shoulder, but certainly can become symptomatic. So
yeah. So your study, you didn't control for variables such as like someone at that age having a growth spurt, training intensity, their throwing mechanics, what other sports they played, things like that. Do you think if you'd looked at those variables, do you think there would be anything relevant to those in regard to widening?
Well, certainly.
I know I'm asking you to, this is probably asking you to speculate a lot, but
well, those are great questions. That and now people are starting to. I haven't seen any of the any studies with thousands of patients yet, but the people are starting to pull data from little leagues, and people are interested in this enough that I think some of that will be teased out. But this study was 79 kids, and we could make some conclusions about the fact that the physis almost always shows changes. Didn't correlate very well with symptoms, that kind of thing. But it's a great jumping off point to talk about, things about throwing shoulder, both in kids and in adults. So I think it's obviously an old study, and there's a lot of data since then, but it's a really cool topic, I think.
No, it's excellent, and it's I think it's timely because I see this a fair amount in our clinic with younger kids like this. So Terry, can I get you liven up here just a little bit?
Sure. I think one of the things that.
Well, wait, Terry, I got a question for you.
You got a first question? Okay, go ahead.
I got a first question. You can elaborate on it.
You can't just talk. You got to have him ask a question.
Yeah. No, I know. You're telling Terry. You're trying to straighten Terry in line. Yeah. All right. So Terry, what I want you to talk about, if you don't mind, is tell us what clinical symptoms, signs and symptoms that a therapist, trainer, or physician will see. And so if they have the problem, what are those symptoms? And then how do you go about treating it? And how do you monitor that? When do you let them play? How long do you let them rest? What's your normal routine and progression if you have someone that has open physis that's widened more than the other side and you think is symptomatic? How do you handle that? What do you look for, and how do you handle it?
Well, obviously it starts with the discussion with the physician, with the therapist, the parents, because one of the things that's really changed, all of these kids, when this study was done, we didn't have all of the showcases, all of the around the year, activities associated with throwing. It used to be that, and I'll use myself as the example. I pitched, played third base. As soon as baseball was over, I played football. As soon as football was over, I played hockey. I grew up in Ohio. Okay. But we played different sports. Now the problem is we've got these kids that are year round. And so load management was something that happened because of our seasons. And so now what's happening is Dr. Mair sees a kid that this kid's thrown as hard as they possibly can because velocity is king. They're trying to, and they have coaches that are pushing them. They have parents, of course, who think that this is going to be the scholarship and they're going to then play in Major League Baseball. And so it's really changed. But I think that the underlying management we've got to always think about is the reality of the kid. And so we always start with, we look at what kind of loads, what activities, what patterns, and then we start from there to pull back. When you said, when we let them go back, well, obviously they got to be asymptomatic. And then but when you start talking about progressions, you know, these kids think progression is next week. And it's a real challenge. And Dr. Mair, what would you like to throw in on that?
Well, I think you make great points that I think are the most important parts when you talk about youth throwing and the truth of the matter is when kids have pain with throwing, the treatment is rest. Once we get into the late high school, college age, we got different things we sometimes do, and there's a lot of physical therapy involved, and certainly working on the core and making sure the posterior capsule stretched, all those things that we do in the older, and the scapular stabilization, all the things we do in the older kids can help, but the most important thing is rest. So the best thing to point out with kids is not so much how we treat them as much as education of parents and coaches. And there are a lot of cool studies on that about how much misinformation there is with parents and coaches. Your point about year-round baseball is the number one thing that comes up all the time about why we have problems with kids and throwers, and the fact that not as many kids play multiple sports. I think there's studies that show that kids that play multiple sports are more likely to end up in the major leagues and in the NHL and the NFL, all those things. Some of that's because they're the best athletes.
They're the best athletes, exactly.
But they also don't mess up there are even studies that show that if you play baseball in Ohio, you're less likely to get injured than you are if you play in Florida, because there's some limitations on what you can do during the winter, which is helpful.
Yeah, I've seen.
Well, we throw snowballs, but we don't throw.
Right.
Yeah.
And the same thing happens in Michigan.
You don't throw the volume.
Same thing happens in Michigan. You can only play for a short time.
Right. Yeah, and there's that bear that out, that the injury rates for baseball tend to be higher in the South. So the most important thing is education of parents and coaches, what to look for. Obviously Andrews gets tons of credit for being the big driver of education with pitch counts and things we're going to talk about in the next paper. But they did some studies on pitch counts and different things, but their number one factor was throwing through fatigue, as far as injuries in the young kids, injuries in the high school kids. He talks about so the biggest thing is education of parents, so you don't, and again, we're going to talk about pitch counts in the next paper, but what to look for in a kid. So in a young kid, they may not want to tell you if they need to come out of a game. So are they losing their velocity? Are they losing their command? Is their elbow dropping? Have their mechanics changed? People talk about increased time between pitches as a sign that a 12-year-old may be starting to get tired. So there's education of coaches and parents of what things to look for when they're fatigued, which is probably the most important thing that we can do with this, is maybe more education of how to avoid these problems because treatment typically is rest.
Yeah, and one of the simple things for the PTs, when you get them in the clinic, when you go to some very basic things, stability, standing on one foot as an example, having them do very simple things, you'll be amazed at how uncoordinated and under muscularized, if you will, a lot of these kids are.
Yeah. So that brings up a good question, Dr. Mair. Like, so can you do, other than radiographs, can you really screen people for this problem? Or do you almost have to wait till they have symptoms, right? Does it make sense to screen kids by doing x-rays of their physis to see if and that's a little overkill, would you say, or?
Yeah, that's certainly overkill. I think it depends on the age group you're talking about. Again, for the really young ones, the 11-year-olds, 12-year-olds, even younger, the key is education of parents about not playing year-round baseball. The recommendation from the pitch smart people at AOSSM and Andrew's group is going 4 months a year without picking up a baseball. I think USA Baseball says you should go 3 months a year without playing at all. So those kind of educational things. For the high school kids, there's a lot of things you can screen. Probably the most important things are, we talk about your external rotation may be increased 20 degrees. If your internal rotation is decreased more than 20 degrees, then if your total arc of motion is down, then you need to be stretching your posterior capsule. So that's an easy one to screen. Obviously, scapular dyskinesia is another one that we look for that's a little dicier because there's some studies that show that almost all pitchers have a little dyskinesia for the same reasons they have x-ray changes, but really something to work on. And then, as Terry mentioned, probably the most important thing is strengthening the core, strengthening the legs, and making sure that mechanics are good, which again is, that's in the eye of the beholder as well. But,
So when you see these players, so like you would see this player probably before I would, right? So they would have shoulder pain or whatever. And unless I'm working as an athletic trainer, if I'm working as a physical therapist, they're going to come see you. You're going to find they have this problem. And then you're going to have them lay off of throwing for a little bit, probably maybe before they come to therapy. Usually what I notice when I see these kids that have this, by the time they see me, they usually have some scapular dyskinesis. You're right. And whether that's part of the pathology or not is debatable. You're exactly right. They usually have a little loss of motion, which is normal in their throwing side. Well, not normal, but more loss than the normal loss that we see with the normal gain and loss that we see. But also usually some cuff weakness. And then the other things you're talking about, the trunk and the core. When you see them initially, do they show up with all of that weakness? Is it, and I guess maybe I'm asking, which is the chicken and which is the egg? You know what I mean? Did they have all those problems, which maybe then caused excessive stress to the physis, or did having the physeal problem from too much throwing actually cause those changes that you see clinically? Which happens first, or do we know?
Well, I don't think we know. It's a great question, and I would assume in some cases it can be either. I think, and they feed off each other. But I still think, especially in the younger group, what Terry was talking about is probably the biggest thing is kids that are pitching too much and don't get enough rest, and it probably starts with overuse problem more in the showcases, as you mentioned.
Yeah.
It's it probably starts more with an overuse problem in the younger ones. The older ones, a lot of it is core weakness and scapular issues, tight posterior capsule, all those things that we're better at working on. About 14 or so, when the growth plates start to close, or at least become less of an issue, I guess the shoulder may close later than that. But that's, people have talked about whether you should throw curveballs when you're 12, and I think the studies are pretty clear that a well-thrown curveball is actually less stress than a fastball. But again, the problem there is with mechanics. So most 12-year-olds don't know how to throw a curveball properly. So it leads to problems. So to get back to your question, I think in the younger kids, it's probably more of an overuse problem. In the older kids, a lot of it is improper mechanics and improper conditioning, improper core, and the things that we're better at fixing.
Yeah. All right. We have some we have a couple, well, really one question. There was one question, one comment. One comment said, I love the Duke shout out. So Rosie, great. Rosie must be a Duke fan. And then we have a question
No,
from
I can't be
Terry
a Duke
Black.
fan anymore.
Well, she must be. She loves the shout out.
Well,
we both cheer for the team in dark blue.
Yeah. That's problematic for me now.
But so, yeah. Okay.
Not a lot of Duke fans here in Kentucky, but that's for another day.
So we have another question from Terry Black, and I think I know the answer to this, but I'm going to let you answer, Dr. Mair. And he's asking, if the growth plate is widened, will the bone be longer? And could the widening actually be an advantage for a thrower?
Great question. I think there are studies that show that the dominant arm in certain sports, not just throwing, but tennis and things, is slightly longer. Whether that's an advantage or not, probably debatable, but certainly the changes at the growth plate are probably all part of the spectrum of the increased rotation, increased retroversion, which leads to more extra rotation, which most studies have shown are adaptive and helpful, and not only decreases injury, but probably allows you to throw with more velocity. So the worst patient is the kid who's never thrown a ball at all and then decides to play baseball when he's 15. And honestly, there are studies that show that's a problem because they don't have that retroversion.
In the old days, remember we used to say left-handers were weird and they blah, blah, blah. And the truth was left-handers frequently were discouraged from becoming pitchers. And then when they actually started pitching, they were already too far along to develop some of the adaptive changes. And so if you looked at the injury patterns in college players back 20 years ago, it was very distinct. There were very different patterns for lefties versus righties. And it was because they didn't throw enough when they were little.
Well, now everybody is lefty. They encourage them to be a pitcher. That must have been back when.
Don't go there.
Okay.
Yeah. Let's just leave that one alone. Yeah. That was like a home run he lobbed to you there, Dr. Mair.
Yeah. The left-handed thing is interesting because, it looks like lefties throw different, but if you look in a mirror, I think most people say that's really not any different. It just looks cool when you throw left-handed, but that would be another kind of cool study to see if there's any differences with lefties. And now honestly, lefties are more likely to be pitchers than there's certain positions they can't play.
Exactly.
Yeah. All right. So one more question, Dr. Mair, before we go to the second study. So which one we'd like to ask authors of studies that, when they did the actual study, if you were to conduct a follow-up study similar to this, what other variables or outcomes do you think you would have liked to add to it to maybe improve on what you found with this study?
Well, if we really wanted to find the answer to one of the questions we were looking at was the retroversion question in the younger kids and when it changed, or if it was kind of a gradual thing. And again, the range of motion tended to look like it was gradual over time, which would make sense. But if you really want to do that study properly, you probably need to do CT scans. We proved that because at least with open physes, that funky X-ray didn't work as well as the study in adults showing it worked.
And IRBs don't like you doing CAT scans for research on kids.
Well, no, you would have probably shot it down anyway. But and then obviously the bigger numbers would have been helpful. And then We actually tried to bring it back, a lot of these kids, and get some longitudinal data. We never published it, but we did bring them back 6 years later, the same group, but the numbers were fairly small. I think we got 30 some back.
Yeah.
But a big longitudinal study on these kind of changes would be good, and I'm sure those are coming. I think people are starting to get real databases on little leaguers and things to look at some of these trends.
Yep. Great. All right. Well, let's move to our second study. We've got probably about like 20 minutes, 25 minutes left here. So our second study is by, it's actually Dr. Mair told us, it's his daughter, Haley, and Tim Uhl is also on this one, and then several other authors. But the title of it is Effective Pitching Restrictions and Mound Distance on Youth Baseball Counts. This was published in 2022 in the Orthopedic Journal of Sports Medicine. And the purpose of this study was to examine the effect of varied pitching rules with regard to pitch counts and mound distance on the number of pitches thrown in youth baseball leagues. And they hypothesized that pitchers would throw more pitches in leagues with inning restrictions versus leagues with pitch count restrictions. And they also hypothesized that more pitches would be thrown in leagues with longer mound distance from pitching from the mound to the home plate. So one thing that caught my attention right off the bat, Dr. Mair, is that this reference here it's the first paragraph here. 5% of all youth baseball pitchers sustain injuries that are significant enough to require surgery or retirement from baseball. That seems like a lot. 5% of youth baseball players just out of the gate end up having problems that require surgery or them to not throw or play for the rest of their life. That just seems horrifically high to me. Is it to you, or?
It does to me as well.
Yeah.
And that, I'd have to see where that came from. And obviously there are a lot of variables in there, but certainly if you look at all the different between shoulder and elbow and other things that can go wrong, I guess there's certainly some career enders in there.
Yeah, no doubt.
That and just the fact that maybe they've had enough once they get pain from throwing.
Yeah, that could be. Can you, so for the purpose of this study, can you define the two different pitching restrictions that were used within the study of the youth baseball pitch counts? So
a little background on this study was a lot of the credit for this study goes to Robbe Ullery, who's one of our long-term trainers here at the University of Kentucky, who works with us with a lot of our high school athletes and was involved with a lot of outreach in the younger kids and things. And he had this really good data set. So there were three different, there were different leagues basically, and some of it was determined by where you live, and then some of it was Little League versus Cal Ripken here in Lexington. And they all had excellent data with regard to pitch count numbers because they all had to track it, and they all have a little app. I think that every coach is required to track every pitch basically to try to keep people within the rules of pitch counts and things. So he had this incredible data over 2 seasons of literally every pitch that was thrown in these 3 leagues, and they all had different rules. So it allowed us kind of a cool control group to look at the data that my daughter ended up, and she's an ophthalmology resident now, but at the time she was applying to medical school and things, and so the thought was, with these different rules, how would it, and we didn't have any injury data or things, so we can't say this rule led to more injuries and things, but it did lead to different findings with regard to pitch count. So basically the different rules were one league had a rule that Little League rules were, as you've seen, when they play the Little League World Series, they could throw 85 pitches in a game, at which point they have to take several days off. And then if they throw, I don't know the exact numbers, I think I had them pulled up here, but over 45 pitches, they got to take a couple days off, that kind of thing. So they have very strict rules on Little League about pitch counts. The Cal Ripken League at that time basically just said you can throw 6 innings a week and you got to have 2 days rest. When you throw one day, you got to at least wait 2 more days to throw again. So it wasn't based on actual pitch counts, but it was based on innings. And then there was a third group of the Cal Ripken with the same innings rule, but they had a 50-foot mound distance, whereas the other 2 leagues had a 46-foot mound distance. So basically we had 2 years of data on 3 different leagues with a way to look at what led to bigger pitch counts and the amount of pitches thrown both for the year and with different pitchers and per game, all those things. So it's very clean data. I mean, obviously you can't look at all the things you want to look at with regard to which ones led to injuries and things, but there were some pretty interesting findings. So that was the basis of the study. And so you had 3 different leagues with different rules and different mound distance, basically.
Yeah. So let me just kind of explain the results here real quick. There's no significant difference in the seasonal pitch counts or innings pitched noted between the Eastern and Southern leagues, which differed only in their pitching restrictions. Southern League was with the longer mound distance was found to have a higher seasonal pitch count per thrower. So the league that had a longer mound distance actually had higher pitch counts per thrower than the South League. And then the Southeastern League also had significantly larger number of pitchers who threw more than 600 pitches per season. So the South League, which had the longer distance, had more pitches per thrower and more numbers of pitchers who threw more than 600 pitches per season. So why do you think that is, that the shorter mound? Yeah, go ahead. Sorry, I'm interrupting.
So the 600 pitches for the 10-week season was kind of the cutoff because there was an old Andrews study that showed that was about the threshold for increased injuries. So that was a good number to pick. So the reason, well, first of all, the 50-foot mound distance, some people around here call that the Trevor Gott rule. So Trevor Gott was a kid who played here in Little League. He played for University of Kentucky. He made it to the major leagues. I think he's just retired recently, but he was throwing about 80 miles an hour when he was 12, which, as it says in this study, correlates to over 100 mile an hour from major league distance, which is pretty hard for a 12-year-old to hit. So they had a Cal Ripken League with a 50-foot mound, primarily not for any of the reasons we're going to talk about as far as pitch counts, but because for the kids that were throwing really hard, it made more sense to back them up a little, give the batters a chance, basically.
Yeah.
But the interesting thing was that the 6-inning rule we thought would lead to higher numbers of pitches for the season, and it didn't. It was actually okay in that regard. Now, it did lead to pitch counts over 100 pitches in a game that went up to 100. The highest one was 135 pitches in a game, which seems kind of insane for a 12-year-old. I mean, our pitcher just this past weekend pitched a complete game and got to 120 in college, and he was pretty fatigued, and there was a lot of thought about that was the longest he pitched, and that, to have a 12-year-old pitching 135 pitches is probably not ideal, and certainly you would think that would lead to higher injury. So to get back to your question, the one with the 50-foot mound was actually where we saw higher numbers for the season and some games with higher numbers, and there were a couple reasons for that. One, there were more pitches per inning, which probably because it's harder to throw strikes or because the kids could hit it better. And there was also a tendency for the top 3 pitchers to pitch more in those leagues, in that league with the 50-foot difference, maybe because only the best pitchers could be effective at 50 feet. So it was a higher usage rate for the better pitchers, and more pitches per inning tended to be the reasons for that. So the 50-foot distance led to more pitches for the season, more so than the difference in what the limit was and how you could pitch.
Yeah. The several things here. Number one, so they had in the South leg, which had the longer distance, there were more pitchers that threw more than the 600 throws per season. And then in the same article, they described that a study, who was it? Lyman study, which I think is an older study, found that throwing more than a cumulative of 600 pitches in a season increased the risk of elbow pain. So we know that, but they threw more than 600.
Well, that's how we picked the 600 number, because that Lyman, and he's a Andrews protege, or was working with him at the time. Andrews' name is on that paper too. So that's where we came up with the 600 as our cutoff.
Yeah. And then so more people, coaches and parents allowed their kids to throw more than 600 more often at that distance. And then, so how does, there was some discussion here about like coaching behavior, and you mentioned things about parents, educating parents. And the reason I ask about that, what your thoughts on that are related to this study, is that this paper also described that 46% of pitchers reported having been told to throw despite having arm pain. And the fact, I guess, that some parents actually believe, there's somewhere else in here, it said something about parents believe it's okay to throw with arm pain. Both of those really sound kind of problematic to me. You know, how do we?
That wasn't from this study, but it's in the paper from other.
Yeah. It's referenced.
And it's referenced. And there are some crazy studies looking at parent, thoughts. And probably the classic one was, I can't remember the exact number, but some high number of parents thought that that it made sense to have your UCL reconstructed when you're 16, because you'll throw faster and be less likely to get injured later, even if you're asymptomatic. I mean, Andrews talks about having people show up at his clinic with their 16-year-old saying that they want him reconstructed now so that he, can throw faster and make it to college and be less likely to get injured and things, even though they weren't having any symptoms. So, but yeah, there are a lot of crazy thoughts about what parents come up with.
Well,
what was your other question there?
I misquoted that it wasn't parents who believe their children that have arm pain is okay to pitch. It's parents who believe that children should it's okay to pitch when they have a tired arm, or at greater odds of having a child with an injury than those who disagreed. So someone who says you shouldn't throw when your arm is tired is less likely to have a child that has an injury than a parent who says, yes, it's okay to throw when it's tired. So it was tired and fatigue, not pain. I'd misquoted the.
It shows that education can work, though.
Yeah. But you got to get it out there. I mean, it's crazy what you hear from parents, I think, when they come to see you when their child is having problems.
Okay. If you got to remember, in the state of Indiana, there were a lot of kids held back one year when they were in elementary school, so they'd be better athletes at the high school level for basketball. So it's not just baseball. Let's be careful here.
There's a lot of redshirted kids still in every state, I'm sure.
Every sport, yeah, and a lot of sports. So, Dr. Mair, which do you think is more important? I'm going to put you on the spot here. Is it more important to have pitch count limits for single games, or if you had to choose one, pitch count for single games, or more for the entire season?
Well, I think both are important. I mean, probably single game is is clearly important. In fact, Cal Ripken doesn't have these rules anymore, so nobody goes with innings anymore. I looked that up to make sure that was true, and I felt it was probably true. And so basically, I'm sure it wasn't because they saw our study, but the idea is if you just go by innings, you're going to have people pitch too many pitches in a game and too many.
In each, yeah, yeah.
You know, both of them can be problematic. I think the Andrews study showed that cumulative was more important. The ones that got over 600 pitches in a 10-week season were more likely to be injured than necessarily one game, although pitching 135 pitches in one game can't be good for a 12-year-old.
Yeah. Well, and the other question I had was related to this also is that, you know, in this age group we're talking about, there are, you know, some, let's say like a 13, 14-year-old, there's some 13, 14-year-olds that look like they're 10. And then there's 13, 14-year-olds that look almost like me. Are the pitch counts, I know we set them as like an average of what they should be, but could they be skewed a little one way or the other? I mean, the older.
So the people that have set these pitch counts that obviously have looked at all the data and things, it gets a little more each age group, right? So to your point, the 14 or the 12-year-old that looks like he's 14 might do a little better with a higher pitch count, obviously.
Yeah.
If he's you know, if his true age is closer to 14, I guess you'd say his growth plates look like they're 14, that kind of thing. The other problem with all these studies is that one of the biggest things that we found in looking at some of these or asking people is that, you know, it's great to say you should only throw, you know, a certain number of pitches, 600 pitches a year in the 10-week season. A lot of these kids, they pitch on one team and, you know, they're allowed to throw 85 pitches is the most now in Little League and Cal Ripken for a 12-year-old. But then they go on some travel team on the weekend and throw again, and that doesn't even count because these are all league mandated things where if you're on a different league, you can basically double it, which is hugely problematic, obviously.
Yeah, another study go ahead, Barb.
Sorry, the bottom line is they're probably all overthrowing.
Yeah, a lot of them are.
If they're playing multiple leagues or whatever, they're probably all
Well, then the other thing, I remember reviewing a study once where they actually looked at the number of like throws, you know, the bullpen throws, and then their number of warm-up throws as they come in each inning. That's not even counted, and that just adds to it astronomically. So you're counting the number of actual throws when the game's like literally live, but they're throwing all kinds of throws to warm up in between innings, things like that. So that 600 number or whatever 135 numbers, it's totally blown by when you look at all those other throws in context.
And remember, that's a great point too, and other people point that out. You know, even at the highest levels, they don't really look at that. Which, you know, I've often wondered if you're thrown over to first base 20 times because a lot of those throws are reasonably high intent throws, you know, those probably should count. But
the other part of it, remember, these kids, when they're not pitching, they're typically one of the best players on the team. What are they doing?
They're
shortstop, third base.
Yeah. Well, the recommendations for USA Baseball and the Little League recommendations are that if you come out of the game as a pitcher, you shouldn't be a catcher because they obviously throw the next most. And you know, there is discussion about catching is probably the one position that adds to your throwing numbers enough that it's
that's like your worst nightmare, isn't it? When you see the pitcher, when you have a young pitcher with some kind of shoulder elbow problem, you ask them what other positions they play, and of course they always say catcher. You're like, oh god, great, okay. Terrific.
Yeah.
How about first base? You know, what's wrong with first base? All right, we have a couple of questions. We're almost done here, guys. We have a question. First question I have for you, Dr. Mair, I believe was related to the Physeal problem that we talked about. Do you think there may be greater benefits for pitchers in maintaining submaximal throwing, I think they're saying when instead of shutting them down completely when they have their shoulder problem, would there be any benefit for pitchers in maintaining submaximal throwing rather than completely shutting down throwing activities for X number of weeks or months?
That's a good question. I mean, I guess if you're shooting for maximal retroversion, you're gonna let them through.
Let
But
them continue.
I think most of us, obviously I don't know the answer to that. I don't know that anybody
Yeah.
does. And I've
I hadn't
never
even thought about it
before.
till the question came up. Yeah,
It's actually a pretty good question.
Yeah.
But I think most of us would say if you're having any pain in your 12, you probably shouldn't throw it all until you're asymptomatic, and then there's got to be a graduated interval
return
program to get back. But reasonable question that I don't know if anybody knows the answer to.
No.
Yep. All right. And then there's a question. I think we answered this one from Wesley Chun. Has anyone looked at bullpen and warm up, which is what we talked about? Yeah.
Yeah. Great point.
Yep.
That. Yep.
Okay. Well, guys, I think we've got like a minute or two. Do you, Barb, Phil, you guys got any questions? You got anything you want to ask him before we move on? No? Terry, you got any final thoughts? Terry's always got a final thought or 5.
We're just blessed being able to do what we do.
That we are, Terry. Terry, Dr. Mair, thank you so much for joining us tonight. We really appreciate it.
Yes, thank you.
Great topics, great discussion. We'll hopefully we can have you back sometime in the future.
Appreciate it, Rob,
Thanks,
and everybody.
We'll let Avery jump in. Avery is a ATI employee. He's a ATI sports residency graduate and a current upper extremity fellow out in Arizona. I'll let Avery go ahead and jump in here and kind of formally introduce himself. And Avery, I didn't even ask you before we started if you had slides you plan to share. If so, I will make sure I can make sure you can share. But go ahead and jump in, introduce yourself real quick, and go ahead and try and share your slides and make sure that that works for us.
Yeah, thank you. I'm Avery Epstein. I'm, like you said, current ATI upper extremity fellow. I'm doing my fellowship out in Arizona now with the Chicago Cubs. Let me see. It says sharing is not turned on. I do have some slides. I was trying to think about how I could add to this awesome panel, and I'm going to try my best. Let's see. All right. Should be working. We good?
Yeah, it usually takes just a second. Yep, there you go. And then
perfect.
Good. Yeah.
Sweet. Okay. So the question I kind of pose, making this case related, is when should I be concerned about a growth-related injury? Hopefully this can tie into the articles that we kind of talked about with Journal Club. Cases here that presenting on would be a 10-year-old male baseball player and swimmer who's in 5th grade, complaints of medial elbow pain for 3 months, evaluated in January. He only played the field this fall and did not pitch. These are both Southern cases here, so they pretty much play baseball all year round. The first case is a pitcher and a catcher, so kind of what we just finished talking on, sort of like worst case scenario as somebody who's got a suspected growth plate injury. Pain with throwing and complains of recent pain of picking up his backpack. So some sort of like valgus load trying to throw the backpack over the shoulder. And then the second case is a 13-year-old male baseball player, 7th grade, complaints of medial elbow pain after 1 pitch, evaluated in March. This is his middle school season now. Summer ball starts soon, in which he will participate in his town team and a showcase team at 13 years old, which is not uncommon. Pitcher and outfielder, not currently playing, and this is his first season on the big field. So just going through like the subjective information, try to think of like things that would like stand out to me as to maybe we need to look into something further for this. So these are kind of what we highlighted. So this first case on the left-hand side being a swimmer, so they're doing another upper extremity sport. And then kind of a long time complaining of discomfort. Catcher, we talked about as not the most ideal way to settle down the elbow. And then pain with picking up the backpack. So now ADLs are affected. I think on the right side here, 13-year-old kind of stands out to me because in the baseball realm, as soon as you turn 13, you go to the big field. No matter if skeletal maturity is there or not, you're going into 60-foot mound, 90-foot base paths, and over 300-foot fences. One pitch, so we're kind of thinking potential like avulsion here, and then obviously the high volume playing on 3 different teams. The clinical questions that I kind of just think about in my head as I'm differentiating between a potential growth plate injury would be any growth in the past 6 to 12 months. So asking questions like any increase in height, change in shoe size, pants they're turning into floods, and then any change in field size would be the next big one. So around 7th grade, that 13-year-old range is when the switch happens. So anybody in that kind of realm is going to be somebody that you want to put a red flag next to. Participation in other sports or activities. Are they doing other upper extremity activities? And if the answer is yes, then they're never really giving their shoulder elbow a break throughout the year. Strength training or arm care routine. I think in this population, it turns into a question of, should I be doing something, or what do you mean I have to do something extra? So I think that's a fun thing to sort of implement in some of these kids' heads. And then volume with training or playing. So like what was talked about earlier, really the pitches during game are going to be the only thing that are tracked, but there's a lot of throwing and activity done outside of just those innings that are being played. So just a quick example of like, this is the reason why those 13-year-olds are kind of like a big question mark when it comes to growth plate injuries, because baseball doesn't necessarily care about skeletal maturity. You're 12 and under, you play on a small field. You're 13 and older, you play on a big field. And there's no, the Cal Ripken League might have a little bit of a better transition period at kind of 11 and 12 playing in a slightly bigger field, but really nothing is necessarily preparing some of these kids to make that leap. Okay, objectively, pretty similar here in the 2 cases. So positive milking maneuver, valgus stresses at 30 and 0 degrees, and then limited strength. I think the one that stands out to us as clinicians would be positive valgus stresses at 0. Creating gapping pain would likely indicate some sort of growth plate injury. And then just here would be like some range of motion examples of what these kids were kind of going through. So, painful extension, painful flexion of the elbow, not ideal. You look at some of their shoulder measures, they're probably relatively normal in a thrower at this age, although the horizontal adduction down here would be limited. So things that you can work on while you're not necessarily attacking the injured tissue. So what's next in this population? Are we treating them? Are we treating and referring them, or should we just refer them? What can we do now? So while we're waiting for a potential image, if you're the first clinician that they're seeing, what can we do now? The question that they're going to have, the parents are going to have, are should they be able to play, and to what extent should they be able to play? And then the last question we kind of have to ask ourselves as clinicians is how can we limit risk in the future? So I think they're all relevant questions. We know that as somebody is growing, they're going to be at risk for these types of injuries, especially if they're kind of overusing the joints that are at play during their sport. So kind of the things that would be appropriate in this scenario. So likely for both of them are going to be a treat and refer. So imaging is going to assist in decision-making. Basically timelines for healing would be appropriate here. And we can definitely do stuff as physical therapists and clinicians to make sure that they're getting better. So we can work on shoulder range of motion. We can work on, shoulder strength in the meantime. There's things that we can do that won't necessarily put them at risk. intervention. So already kind of talked about, making sure that things are looking good for when they are able to go back onto the field or when their bones are healed. I think the biggest thing in this is educating the athlete and the parents on risks of overuse, especially with the ones that are, playing on multiple teams or participating in other upper extremity sports. And then I think the thing that creates some buy-in is like allowing these kids to have like some degree of participation. So if hitting isn't bothering them, then we can argue that swinging a bat may be beneficial to let them continue participating. Once they're healed and we're not impacting the timelines of their tissue, okay to get them back into activities that aren't going to put them at risk, as long as we're concurrently going with a return to throw program that's appropriate. And then limiting risk of re-injury. So they don't need a million exercises to make sure that they're staying healthy. They need something that's simple and effective, and something that they can kind of monitor on their own. So for a lot of these kids, it's going to be difficult, but getting parent buy-in is going to be important too, because they can be there at all of their events and make sure that they're adequately treating their arm. And then just lastly here, a little kind of flow chart that I've kind of historically gone through to make sure that we're hitting all the right stops in our return to sport for these kids would be initial presentation. So asking those subjective questions, I think we get a lot more information out of those, especially with this population, because we can easily tease out if they've sort of increased their workload or seen a change in field size or something like that. Red flag screen, obviously, we're making sure that these aren't drastic issues that need to be seen by somebody else before they come to physical therapy. And then the physical exam usually is a good way to figure out what's kind of going on with each of the athletes and make sure that we're not missing anything to prepare them to succeed when they get back onto the field. The imaging decision is probably going to be the most important part of this flow chart here. Persistent symptoms, loss of range of motion, gapping at 0 would be kind of your red flags as to, hey, I think this person needs to get an image and make sure that they're sat down for the appropriate amount of time before we get them back into competition. And then PT intervention, already talked about, respecting healing tissue, and then modified activities with an appropriate return to throw program. Making these kids feel involved is all that they want. So trying to shut them down completely is going to be super difficult, especially with, telling a 10-year-old that, hey, you're not going to be able to go play wall ball with your friends at recess is a tough thing. But making sure that they understand the reasons why behind it would be very important. Reduced risks of re-injury would be workload monitoring. So a simple, hey, how does my range of motion look or feel today? Am I having pain before I throw? I think are important things that kids can look at themselves in the mirror and say, maybe I shouldn't go out there and throw today if my arm is hurting. Having the parent buy-in is going to be beyond crucial to this population, because if they know what they're looking for, then we're in a pretty good spot. That's all I got.
Great. Thanks, Avery. That kind of helped us tie everything together. Appreciate you jumping in there with that. Good. If anyone has any last minute questions, this is your moment. 5 minutes left. We're going to give you 5 minutes of your evening back. Next month is our 50th episode. Just FYI, anyone that's still on here, we're going to do a little date change. We'll get that posted to the website. We're going to bump it out a week due to some scheduling conflicts. So it'll be June 24th, I believe. So instead of June 17th, but we will start getting some advertising out here soon. We might do something a little bit fun for the 50th anniversary. More to come on that. But we hope to see you next month. So thank you, Terry. Thank you, Dr. Mair. Thank you, Avery. And of course, to all of my lovely co-hosts. We'll see you next month.
Just want to add, for sports health, for an arm care program, a great reference is Kyle Matzel. He was one of our PhD students, and Tim Uhl and I published with him. But in Sports Health 2023, he's got a really nice arm care program. For those of you who might want to peruse such.
Excellent. Thank you.
Thanks, Terry.
Great hint. Thank you.
All right, everyone. Have a great night. We'll see you next month.
Thank you.
Yeah.